So we will start the initiation, optimization, and intensification of injectable therapy in type 2 diabetes mellitus. So if we look into the different types of anti-diabetic drugs we have and their efficacy and the possibility of different hypoglycemia and their impact on the cardiovascular disease, heart failure, and renal disease, their cost. And you will find that the chart is quite difficult to comprehend, but you have to look into it very closely. It was basically given in ADA 2020, and you can keep it under your in your tabletop to get a ready reference of which drug will be most suitable for which kind of patient. I'll not go into detail of all the drugs, but just to share with you that this chart will give you a comprehensive understanding as far as different anti-diabetic drugs are concerned. In most of the guideline, we find that our A1c target is less than 7%. But as I've told you that this 7% is not a sacrosanct figure. Rather, in some of the cases, we like to have the glycemic control stricter than 7%, as for example, pregnancy, where we like to see that the A1c should be below 6.5. Even at the time of planning for pregnancy. On the other hand, in an elderly subjects who have multiple comorbidities, limited lifespan, we can expect an A1c around 8% or maybe 8.5%, because the major concern in front of us is the hypoglycemia. So therefore, the target of A1c is not a fixed one. The target of A1c depends on the patient profile, but in most of the situation, our target is roughly around 7 to 7.5%. With that respect, we can keep a target of fasting plasma glucose between 90 to 130 and postprandial target between say 130 or 40 to 180. So if we keep the postprandial plasma glucose between say 130 to 180 and fasting plasma glucose between 90 to 130, we can actually achieve an A1c target around 7 in most of the situation, and that is our target in most of the cases. Now, when we treat with insulin, the insulin therapy is basically of three different definitions. Number one, when we start the insulin therapy, we call it as initiation. And second, when we actually titrate the dose of the insulin, then we call it optimization. And the third is that when the first regime is ineffective and we would like to change the regime, we call it intensification. So therefore, we have three parts: initiation, optimization, and intensification. In the last one, we try to modify the insulin regime. So I'll go through the cases so that you can understand how we approach the insulin therapy. Now, this is a 52-year-old male bank manager on glimepiride metformin, complaining of weakness, lethargy, weight loss, and he has a plan for cataract surgery for which he was referred to our clinic, and fasting plasma glucose was 275, pp369, and A1c was 11.4. So he has a very poor glycemic control, despite the fact he was receiving glimepiride and metformin, and he was diabetic for the last 5 years. Now, when to initiate? Now, if you look into different guidelines, then the guideline will tell you when to initiate the insulin therapy. This is basically by American Diabetes Association 2016, and they have said that you start with metformin. If not controlled, you can give the insulin, or you can start with metformin, give the sulfonylurea, so add sulfonylurea, and if this fails, you can start with insulin. So after one agent failure, after two agent failure, you can start with the insulin therapy. Now the second question is that when to start and on the basis of H1C. Now you can see this is AACC, American Association of Clinical Endocrinologists criteria. If you find that entry H1C is more than 9%, then you can start the insulin therapy. If there is no symptom, you can give oral anti-diabetic drug. But if the patient has got a symptom, you should start insulin therapy. So this guideline AC says on the basis of H1C. Now we have Indian insulin guideline as well. I believe that the Indian insulin guideline is a very rational as far as the insulin therapy is concerned. You can start the insulin therapy number one at diagnosis if the fasting PPH1C all are high, or if the patient has got a significant comorbidities for which insulin is the best choice in front of us, or if the patient has failed with oral anti-diabetic agent 2 or 3 agent, having fasting more than 150 pp more than 200 and H1 8.5. So looking back into the patient, we'll find this patient has got a fasting very high, pp high, and H1C above more than 8.5, and therefore fulfilling the criteria to start the insulin therapy. So looking into the three guidelines, you will understand that this patient actually requires insulin therapy, and especially is planning for cataract surgery. As I've already discussed, whenever you start the insulin therapy, our always target is the fasting. And to target the fasting or to control the fasting plasma glucose, we have to give a basal insulin. And if we give basal insulin, it will not only normalize the fasting blood plasma glucose, it will have significant impact on the postprandial glycemic surge as well. So we need to fix the fasting fast. So in summary, if we look into whatever I have discussed, basal insulin can be considered soon after metformin failure. This is one of the guidelines. ADA or basal insulin can be recommended even at the start of the patient with H1C more than 9%. This is AACC guideline with symptom. And basal insulin is recommended when fasting and PP high and H1C more than 8.5 despite 2 and 3 oral anti-diabetic drug. This is in Indian insulin guideline. So these are the three guidelines, and in the summary we can understand that when the guideline says to start the insulin therapy. So American Diabetes Association has said that the basal insulin is the most convenient insulin to initiate the therapy. Metformin, GLP-1, DPOR, sulfonylurea can be continued with basal insulin. So you don't have to change the dose of the other drug, whatever the patient was receiving. So the patient was receiving metformin and sulfonylurea. So we will not change the drug metformin or sulfonylurea, and we just have to add the basal insulin. Do not change, do not alter the dose, and keep the patient whatever the patient was receiving at that point of time. Patient on insulin not at goal. The addition of the glitazone or SGL2 through no potential side effect can be considered. Now, if the patient was receiving basal insulin, then you can add on these drugs also. Now, coming back to the patient, we have discussed that this patient was on glimepiride, metformin, fasting high, PP high, H1C more than 8.5%, and therefore the patient actually qualifies for the insulin therapy. And we have learned that the fasting plasma glucose is the first thing that we should address, and we have looked into the guideline of the ADA who said that you should give a basal insulin at the beginning, because that is one of the best possible method by which we can achieve good fasting plasma glucose. So therefore, in this particular case, we have decided to start basal insulin, that is initiation of the basal insulin. So after you have decided that about the basal insulin, the second question in front of our mind is which one? So if you look into the basal insulin, we have MPH, we have glargine, we have detimate, we have degludec. I have discussed about all the insulin a little bit. Now let us have a look into these four different kinds of insulin in one slide, and you will understand what are the advantage and disadvantage of each and every one. As you can see, MPH duration is 12 to 14 hours. You have to give twice in a day, indicating 2 pricks. And as I've told you, is associated with slightly higher risk of hypoglycemia, especially nocturnal hypoglycemia. On the other hand, if you look into glargine U100 or glargine U300, it has got no peak. It has got a duration of action of 24 hours. Especially in 300 has got a duration of action up to 36 hours, and you can treat the patient with once daily dose, and the possibility of hypoglycemia is much less compared to the NPH. Looking into the detimate, as I've told you, that its duration of action is slightly shorter compared to the glargine, and therefore sometimes requires twice in a daily dose, which is not very comfortable as far as my understanding goes. So therefore, I always stick to either NPH or into the glargine, because these are the two very important insulin. This one is the cheap, and this one is the costlier variety. But we have another very good insulin, that is degludec, which has got a duration of action of 42 hours once daily, possibly have slightly lesser hypoglycemia, even with compared to the glargine. But the issue is that it comes with a very, very premium price. So therefore, we have the cheapest variety with the maximum hypoglycemia. We have the intermediate variety, also a very good insulin, having 24 hours action. You have to can give once in a day, the much lesser hypoglycemia, and possibly we have another one, degludec, which have yet less hypoglycemic issue with respect to the use of degludec is concerned. Now it depends on the patient which insulin will be suitable for him or her, because because cost is an important barrier as far as these basal insulins are concerned. Now, second question is how to initiate, means which dose you will start. To calculate the dose, there are many methods. One of the method is to calculate the dose on the basis of the body weight and on the basis of A1c. So this is one way. This is American Association of Clinical Endocrinology guideline, but we can calculate on the basis of this and start the insulin therapy. The second option is, if you look into the AD guideline, they say you can calculate on the basis of the weight, but you can just simply start with 10 units. I think this is the simplest way to think and start. So I start with the basal insulin, 10 units at bedtime, or sometimes 10 units in the morning, whatever you like, depending on your choice. So the issue is summary, as whatever we have discussed, that we can start basal insulin, degludec, glargine, or detimate at 10 units once daily at bedtime, or you can start the basal insulin and determine the dose on the basis of body weight, which usually I don't prefer. I start with a 10 units dose. So there are few things which we have to remember. The basal insulin regime is the most convenient initial insulin regime, and it leads to long-term reduction in the complication, number one. Number two, you have to give the basal insulin in an appropriate time. As you know that the glargine basically works for 24 hours, and therefore you have to give the insulin same time every day. So if you have advised the patient to take insulin at 9 p.m., you have to give the insulin at 9 p.m. irrespective of the meal. Whether he has taken the meal before or after hardly matters. On the other hand, if you have given the NPH insulin, to give twice in a day and again on the same time, so 9 a.m. in the morning and 9 p.m. at night. So that will actually give the whole day coverage of the NPH insulin. In case of degludec, as because it has got a 42 hours duration of action, therefore your time restriction is much less. So the compliance will be better with the degludec. So the patient can inject the insulin any time of the day. So because it has got a 42 hours duration of action, so you can take any time of the day, irrespective of the meal. So basal insulin should be stored, transported, injected using correct technique, ensuring that injection are delivered into healthy subcutaneous space. And the technique of administration is important. And for that sake, I believe that you have to take help of the diabetes educator who will actually demonstration to the patient how to inject the insulin. Or you also can yourself give a demo to the technique of administration, but make sure that the patient gets the insulin with the right technique. Now, coming to the transport and storage is another important issue in front of us. Insulin remains intact in a room temperature up to 28 days. So therefore, if the patient is using an insulin pen, I usually advise to keep it in the room temperature, because in most of the situation, it usually consumed within 28 days period of time. It hardly matters. But if somebody is buying 4-5 pens or cartridge simultaneously, then he has to put it into the refrigerator, and has to only the cartridge or the pen which he is using should be outside. Now, if the patient prefers to keep all the insulin supply into the refrigerator, then he has to take out the pen before injection, at least 1 hour before injection. So make the insulin into room temperature and then inject. Don't inject cold insulin. And third point is that you have to keep the insulin and the pen, everything, in the door of the refrigerator and not in the freezing compartment. So it should be between the 2 to 8 degrees centigrade, and it should not go below 2 degrees centigrade. Below 2 degrees centigrade means the potency of the insulin will be altered. Now, combination therapy with VD and basal insulin offers is a very complementary mechanism of action, and that will reduce the actually uh, uh, side effects of the insulin. So usually we give tablets in the morning, and usually we give basal insulin at bedtime, and this combination works very well. And in majority of the cases, I must say 70 to 80% cases, only basal insulin with complementary anti-diabetic drug is sufficient enough to maintain a good glycemic control. And you have to fix a target, and you have to clearly discuss about the target with the patient. You see, your target is 100 to 130, because patient often is not satisfied if the blood sugar level is roughly around 120. They feel it is still high. But we have to discuss that the target of glycemic control is between 90 to 130, and 120 is pretty much inside the target, and you don't have to uptitrate it further, because that may lead to the development of hypoglycemia. Now, long-acting basal insulin analogs are associated with the least risk of hypoglycemia, and that is why I have told you that it is quite safer to use long-acting insulin even compared to the sulfonylurea. So therefore, don't afraid of starting long-acting basal insulin, which are quite safe, but at the same time, you have to advise the patient to self-monitoring his or her blood glucose level and adjust or titrate the insulin dose. So coming back to the patient again, this bank manager with OAD failure, we have decided to start the basal insulin. We have decided that we should give the dose of 10 units, and we have discussed with the patient regarding the insulin, and we have started Glargine 10 units at bedtime subcutaneously. So after giving Glargine, the symptoms have improved, and the patient now have fasting plasma glucose 198 and PP 243. So it means the patient has improved a lot, but this is not sufficient for the cataract surgery. So what we will do next? So the next part is the optimization. So it is the dose titration to ensure that the patient receives the maximum benefit from the prescribed treatment. So optimization means we have to increase the dose so that the fasting plasma glucose comes within the normal range or the target range. So how to optimize? So usually we have to titrate the insulin dose. We have to keep a target. In this case, is maybe the fasting plasma glucose value of 80 to 130. We should start low, go with a slow titration, and in case of the and higher targets may be recommended for those patients with high risk of hypoglycemia. Say, as I've told you, a patient who is about 70-year-old who has multiple micro and macrovascular complications, have a short lifespan. I would like to target fasting plasma glucose between 130 to 150. And then we have to modify the insulin dose on the basis of the lowest value of the three most recent plasma glucose value. And titration dose, there are a lot of titration dose available in the net. I use this one as I have already discussed beforehand because it is easier to remember. So with the 140 we increase by 2 units, 160 we increase by 4 units, 180 we increase by 6 units, and if it is 70 we decrease by 2 units, if it is 56 or low we decrease by 4 units. So this titration algorithm I use in my clinical practice. The second question is, it is always better that you educate the patient about the titration. Don't keep the titration technique in under your control. So give it to the patient. If the patient is intelligent, educated, and trained, then the patient actually can titrate his or her own insulin dose. And if he can titrate the own insulin dose, then we expect that that will lead a better glycemic control, as it was found in this important study. And you can find that this is the physician-led titration, which leads to A1c of 8.01. But when it is a patient-led titration arm, where the A1c has gone down to 7.6. So it means if you empower your patient, you will get a better outcome as far as glycemic control is concerned. Now, we have very recently published this important consensus on the Bezel insulin as far as the management of diabetes is concerned, with this three important questions: which one, when, and how. So this you can look into JAPI where it has been published. Now coming into the patient again who was on basal insulin on 10 units. So we have decided to up-titrate the dose of the basal insulin, and we have given the dose of 18 units at bedtime. And on follow-up, you can see after 1 week, after 4 weeks, you can see the fasting is 125, PP is 159, and A1c came down 11.4 to 8.6. So we continued with the same treatment. Now you can see that we have to evaluate that whether there is any problem in the lifestyle or not. We have to check the right insulin technique, whether the patient is taking the insulin at in a right way, and then whether the insulin administration fits in the patient lifestyle, at what time is taking the insulin has been advised, and what will be the ideal time to give this basal insulin on the morning or in the evening. In most of the situation, as I told you, I usually advise the patient to take basal insulin at bedtime. Patient should know the fasting target, and you can consider the titration until the fasting plasma glucose reaches at the target. Now, over a period of time, we followed this patient and found after 12 weeks or 18 weeks, you can see that the fasting and postprandial actually are well controlled, but you can see that the H1C remained at the same level. So this is basically quite frustrating because we have achieved a good glycemic control as far as the fasting and PP is concerned, but patients still have higher H1C. So we are expecting that H1C should come down to the level of say around 7 or 7.5. So if the patient is not controlled, which may not be true for most of the individual, most of the people will achieve an A1c target also with this kind of treatment. Only 10 or 20% patient will remain uncontrolled despite the fact you have achieved a good fasting and good postprandial control. And in these cases, we have to plan the intensification. So when we should stop increasing basal insulin and think about intensify the insulin therapy. As I've told you that A1c is still not goal, though the patient is receiving good amount of basal insulin. There is an elevated A1c despite normal fasting. The fasting basal insulin is within target, but BP is persistently high, and further increase in basal insulin result in hypoglycemia. So in those cases, we have to intensify the treatment regime. Intensification means the modification of insulin regime, adding or changing the therapy to maintain the glycemic control. So this is the third part of our talk. Now, how to intensify? If you look into the ACC guideline, you can see the intensification means that you can add the prandial insulin, basal plus or basal bolus. So prandial 1, prandial 2, prandial 3. So this is the you are adding prandial insulin before breakfast, before lunch, before dinner, or you can add GLP-1 receptor agonist. So these are the two options in front of us as far as the AAC guideline is concerned. Now looking into the ADA guideline, you can see ADA guideline has said that you can add the prandial insulin or rapid acting insulin 1 time, 2 times or 3 times. Or second, you can actually give GLP-1, or third, you can shift the patient from the basal insulin into the premixed insulin. So these are the three options in front of us as far as the ADA guideline is concerned. So we have decided to shift the patient to the twice daily premixed insulin. So if you look into the summary of intensification, when we should intensify, if the basal insulin has been titrated to an acceptable fasting glucose level, but A1c or the PP plasma glucose remains above target, we have to intensify. How we should intensify? Either we add the mealtime insulin, either rapid acting or regular acting insulin. Two, we can shift the patient from basal insulin to twice daily premixed insulin, human insulin or analog insulin. And third, we can add GLP-1 receptor agonist with basal insulin. So these are the three methods by which we actually can intensify the insulin therapy. So premixed is basically a very conventional method as far as our understanding goes, because before this long-acting insulin came into the market, we used to treat the patient with premixed insulin. It is a very simple insulin type because you are giving the same premixed insulin once in a day, then you are actually up titrating twice in a day, and you may sometimes actually go to the 3 times in a day, though I don't do that. Now this is the less dosing error. It is very convenient because we are giving 2 pricks. On the other hand, if you give basal bolus, you have to give 4 pricks. This premixed insulin has got a very good coverage of postprandial plasma glucose and possibly will have better A1c control. So these are the few important advantages of using premixed insulin. As I've already discussed with you, we have a lot of premixed insulin option in front of us. Premixed insulin, we have premixed analog insulin, we have different proportion, 30-70, 50-50, we have proportion of 25-75, 50-50, 30-70, 50-50, and we have co-formulation insulin with aspart and insulin degludec. So we have many options in front of us as far as the premixed insulin is concerned. So this patient, as we have seen, fasting is controlled, PP is controlled. Now we don't know how to adjust the premixed insulin because we do not know whether the breakfast is high or the dinner is high. We have only 2 values, that is fasting and post lunch. So we have decided that this patient, as because the A1c still remains on the higher side, we have to go for intensification from basal insulin to twice daily premixed insulin analogs. Now, to understand that how we can adjust the dose, we can go for continuous glucose monitoring system, or we can ask the patient to do a 7-point blood glucose monitoring. So before breakfast, after breakfast, before lunch, after dinner, before lunch, after lunch, and at 3 a.m. So 7-point monitoring is an option, or otherwise we can go for continuous glucose monitoring system. So after this, we found that this patient has got a good glycemic control during the night time, but has got a poor control in the morning hours. So from say in the 6 to 12 in the morning. So this is basically a poorly controlled, and as because this is poorly controlled, that is why the patient has got a poor A1c control. So how we should shift the patient from basal to premixed insulin? Now you can see that there are method by which we can shift from basal to premixed insulin. Now you can see in the premix there is a 30% is short-acting insulin and 70% is basically the end-page insulin. Now the patient is receiving basal insulin. So the basal insulin component should be the same in the premixed insulin. So the new regime should be started after 18 to 24 hours of the last basal dose. So if usually I give the basal insulin at bedtime, so if I have to shift the patient to premixed insulin regime, I start in the next day before dinner. So when we are titrating the premixed insulin, then usually I look into pre-breakfast and pre-dinner value. And with the pre-breakfast, I try to adjust the before breakfast premixed insulin, and with the pre-dinner value, I usually adjust the before breakfast value, before breakfast premixed value. And for the fast and with the fasting, I adjust the pre-dinner premixed insulin value. So sometimes the largest meal often requires a larger proportion of insulin, and if the patient has got a hypoglycemia, to reduce the dose. So this is not we are actually going through the basal into premixed insulin. Now coming to the patient, as because the daytime patient has got a higher blood glucose control, we have stopped the glimepiride. When we switch the patient to the premixed insulin, usually we stop sulfonylurea. We continue the metformin 2 gram, and we started the biphasic insulin lispro 20 minutes before breakfast and 10 minutes before dinner. And you can see we have given the 30 units. In the 30 units, 70% is basically the basal insulin. So this patient is receiving basal insulin of 21 units, and patient was receiving basal insulin roughly around 20 units. So we have kept the same amount of basal insulin, but there is an increment in the prandial insulin, and therefore we have to check what is the blood glucose level. As I have told you that we have to check the pre-breakfast and pre-dinner, and on the basis of the pre-breakfast, if you get the pre-breakfast value high, increase the pre-dinner premixed insulin, and if you get pre-dinner value high, increase the pre-breakfast premixed insulin. So this is the way we titrate. So therefore, if you look into the premixed insulin, it works best with the predictable eating pattern. The issue is if you take in the premixed insulin in the morning at 9 a.m., we expect that you should take the lunch at 12:30 or 1 p.m. So unless or until the lifestyle is fixed or predictable eating pattern, the premixed insulin will not work, and there will be possibility of hypo and hyperglycemic episodes. Higher total insulin dose requirement and thereby potentially greater risk of hypoglycemia and weight gain, that is an important disadvantage of the premixed insulin. And inability to titrate the bolus insulin dose alone with the actual meal size, that is another important limitation, because it is premixed insulin. So if we're increasing the dose of insulin, both the mealtime insulin and the basal insulin component will increase proportionately, and therefore we cannot increase the dose of only basal insulin or only prandial insulin because they are premixed. So coming back to the patient, we are giving 20 units before breakfast, 10 units before dinner. We find a significant improvement in the in the pre-dinner value was 210. There is an improvement in the fasting, in the PP, and the pre-dinner value. There is from 210, it became 148. Then we have increased the dose little further, and we found it has come down to 128. And then we found that the A1c came down to 7.1, and the patient settled with the with the premixed insulin 28 units before breakfast and 12 units before dinner. As because the glycemic control is fairly good, we advise the patient to visit the eye clinic. So this patient was on metformin, receiving biphasic insulin 20 units and 12 units. Fasting and PP was perfectly controlled. A1c came down to 7.1. We asked the patient to go for cataract surgery. And on the next day morning, when he was coming to the eye clinic, he fell from the bus in the gate of the hospital and had a road traffic accident. When I've seen this patient in the surgical ward after this accident, because he was admitted with an hypoglycemia with CBG 32. So this is an important issue as far as insulin therapy is concerned, and especially when you are treating the patient with premixed insulin. You can see that the consequences of hypoglycemia is multiple. There is a hospitalization and the cost of hospitalization. Hypoglycemia is associated with more cardiovascular complications, weight gain, loss of consciousness, possibility of seizure, accident, reducing the quality of life, coma, death. So there are a lot of complications or consequences of hypoglycemia, and we try our level best to avoid the hypoglycemia. So therefore, we are not happy with this premixed insulin twice daily because patient has developed hypoglycemia. So we decided that let us switch the patient to basal bolus regime, though the patient have to take 4 times in a day, but the basal bolus regime is associated with much less hypoglycemia compared to premixed insulin. So after the hypo episode with the biphasic insulin, we have found that it is better to shift the patient from the twice daily premixed insulin analog to basal bolus. Now, how to switch the patient to the premixed insulin to new basal insulin? Now, you have to give 80% of the total daily intermediate acting component in the premixed insulin as new basal insulin. So if you can see that this patient was receiving, say, for example, 40 units of insulin in the whole day. So, and out of this 40 units, 70% is basically the basal insulin. So 28 units is the basal insulin, and 80% of the 28 units, it means roughly around, say, 22 units, we have to give as a basal dose. And then rest 20%, we have to rest 50%, we have to divide into short-acting insulin depending on the meal time and also the amount of the meal. So this is the titration algorithm as far as the basal bolus approach is concerned. And we have started the virgin insulin 18 units at the bedtime and 444 analog blue lysine before breakfast, before lunch, before dinner. And you can see there's a progressive improvement in the glycemic control, but the pre-dinner value was higher. From 210, it becomes 254. So we've increased the pre-lunch blue lysine insulin. And once we have increased the pre-lunch blue lysine insulin, the pre-dinner value came down to normal, and pre-dinner value came down to normal. And you can see that all the values are within the acceptable limit. So we advise the patient to continue the same and advise the patient to go for cataract surgery, and the cataract surgery was done safely with under good glycemic control. So what I mean to say that first we should start with the basal insulin, which is the very safe insulin therapy. Majority of the patient will be controlled with basal insulin. When the patient cannot be controlled with basal insulin, you have many options in front of us. One of the options is basically the premixed insulin. So we can shift the patient to the premixed insulin twice daily, but premixed insulin has got a slightly higher possibility of hypoglycemia compared to basal insulin and also compared to basal bolus insulin therapy. But basal bolus insulin has got an important disadvantage there to give 4 pricks, which is very, very uncomfortable on part of the patient. However, as the patient developed hypoglycemia with premixed insulin, convinced the patient that you should shift to basal bolus regime if you want to get the cataract surgery done. So the patient was shifted to basal bolus regime, and without any episode of hypoglycemia, patient underwent the cataract surgery very smoothly. When you look into the basal bolus regime, as I told you, that you took given a basal dose which will actually control the fasting blood sugar level. On the other hand, the bolus insulin will control the breakfast, lunch, and dinner. And therefore, you have to titrate the dose 4 times, and you have to check the plasma glucose 4 times to get an idea that how to titrate the before breakfast, before lunch, before dinner, uh, before dinner insulin value, and also how to titrate the basal insulin value. Now, this is a very, very interesting, important study which provides an idea, an input that the basal insulin provides superior glycemic control versus intensified premixed insulin therapy. So, if you look into the premixed insulin regime and if you look into the basal bolus regime, you will find the basal bolus regime will have a better control than premixed control. As expected, because of the fact that in the basal bolus regime, you can actually titrate the dose of every meal separately. In premixed, we cannot titrate the prandial insulin with respect to every meal, and therefore the basal bolus regime will give much better control compared to premixed insulin analog, and moreover, the premixed insulin therapy associated with more hypo compared to basal bolus regime. Coming to the next case, this is a patient who is basically presented with type 2 diabetes, new onset in 2014. When you start the metformin, the patient improved, but later she progressively required more anti-diabetic drug, so that in 2014, to keep her blood glucose under control, we have to continue with the lot of anti-diabetic drug. 3 anti-diabetic drug was prescribed. Over a period of time, say over 1 year, she again lost the control, and blood sugar level goes very high in the 300 range with A1c 10.6 and progressive increase in the body weight from 6.8 to 69 when we started the insulin therapy. Once you have started the insulin therapy, there is further weight gain to 75. Still, the glycemic control was poor, though the patient was receiving glargine of 44 units. So that is a huge amount of glargine patient per unit, more than 30 units. And possibly it is time that we have to intensify the insulin therapy, because only glargine will not be sufficient enough to control the glycemic level. As you can see that A1c is still not goal. The patient is receiving 0.5 units per kg per day daily basal insulin. So the patient 0.5 units per kg per day means almost roughly around 30 units. So the patient was receiving more than 30 units, 44 units. Still the A1c is not under control. Is basically a time when we should intensify the insulin therapy. And we have a lot of options, but if we go for basal bolus regime or if we go for premixed insulin analog, as you know, they are associated with further weight gain, as because patient has already gained 5 kg, we do not want to add on the weight aspect as far as this particular patient is concerned. So we thought let us treat the patient with GLP-1 receptor agonist. Now, basal insulin plus GLP-1 is a very, very good strategy because of the fact that they are very complementary to each other. A combined reduction of fasting and postprandial glycemia and that leads to lowering of A1c level. It has got a lower risk of hypoglycemia because if you give premixed insulin twice daily or basal bolus regime, it will have a higher possibility of hypoglycemia. On the other hand, basal insulin has got a very low possibility of hypoglycemia, and GLP-1 receptor agonists do not cause hypoglycemia. So a combination of the two have a very low risk of hypoglycemia. There is a lower risk of weight gain because the basal insulin do not cause much weight gain, but the GLP-1 receptor actually reduces the weight. So the combination will have low risk of weight gain, and there's a potential long-term disease-modifying prospect with the combination. We have a lot of GLP-1 receptor agonist agent available, and if you look into all these agents, all of them are actually quite safe in cardiovascular background. All of them are not available in our country. We have liraglutide, we have lixisenatide, we have dulaglutide. So we have to choose between these three as far as this particular patient is concerned. So we have started the Guardian 44, and we have added the lixisenatide, which have progressively increased from 10 units to 10 microgram to 20 microgram. And you can see that there is a significant reduction in the Guardian dose from 44 units to 24 units. When you are adding GLP-1, stop the DB4 inhibitors. You don't have to reduce the dose of glimepiride or metformin, but stop the DB4. And if the patient responds, some of the patients respond very nicely with the GLP-1 receptor therapy, and you will find there is a significant improvement in the glycemic control, as you can see in this patient, from 11 to 7.8, and you will find there is a reduction in the glargine dose, and very, very important reduction in the body weight as well. This is our experience of which we have actually published of using liraglutide, and we have compared the liraglutide study across the India, and we have found that all the Indian studies showed a better performance compared to the Western counterpart or the RCT study with that of liraglutide. If we look into the A1c reduction is concerned, Indian patient actually responds better, and if we look into the body weight, then also the Indian patient responds better. So that is why the GLP-1 based therapy is very, very beneficial among Indian type 2 diabetic subjects, even if we compare with that of RCT study results we available with us. So key learning is, as glycemic control deteriorates over time, insulin initiation and intensification becomes inevitable. All of you are aware about that. So don't delay, start the insulin therapy. So always start with the basal insulin soon after metformin failure, or at the start of the patient if A1c more than 9%, or when the patient has got A1c more than 8.5, despite 2 or 3 oral anti-diabetic agents. We should optimize the basal insulin with that of the titration algorithm. Whatever algorithm you want to follow it a titration algorithm, because fasting plasma glucose should be under control with the basal insulin. Intensification is done if fasting plasma glucose is not acceptable, but A1c remains is acceptable, but A1c remains above targets. Now, intensification options are basically 3. Either you give twice daily premixed insulin, or basal bolus regime, or basal insulin plus GLP-1 strategy. Now, basal bolus regime is the gold standard of insulin therapy, but associated with 4 pricks and associated less possibility of hypoglycemia compared to premixed twice daily insulin. Basal insulin and GLP-1 combination is also a very effective strategy for glycemic control, because they are very, very complementary to each other, basal insulin and GLP-1. And basal insulin and GLP-1 combination has a potential prospect of weight loss with lower risk of hypoglycemia. That is an added advantage of this combination therapy. So with this, I conclude, and if you got any question, please make it ready. And
So there's a question in the chat box, sir.
yeah, yes. So
Dr. Bonik has asked, few RX I have seen night basal insulin and morning premix insulin. How much it is scientific?
what is the question?
Sir is saying that I have seen night basal insulin and morning premix insulin. How much it is scientific?
No, I don't think this is a very good combination. If you want to give give premixed insulin twice daily. As simple as that. Because in the premixed insulin, there is an end page which act only for 12 hours. So I've given premixed insulin twice daily. It means the end page will cover the whole 24 hours. 12 units in the morning, one end page in the morning, another end page at night. Now, when you are given premixed insulin in the morning, there is no point of giving the basal or the glargine at night, which has got a 24-hour duration of action. So this is not very rational combination. I think if you want to give a basal insulin, if you cannot control the breakfast, lunch, or dinner, you can add a prandial insulin, say R insulin, or your ultra short acting insulin. So designer ultra short acting insulin. So any R insulin, any glulisine, or the Lispro, or the Aspart, anyone you can give as a prandial insulin. But combination of premixed and the basal insulin is not acceptable.
So no other questions are in the chat box. So one more question has come, sir. How to shift from premix to basal?
Yeah, I think I have discussed this one. You have to understand the some kind of maths. Say for example, somebody is receiving premixed insulin, 50 units in the morning and 50 units at night. So how much is the total dose? 100 units. Premixed insulin is available as 30/70, as 50/50 formulation, 50/50 proportion. So therefore, if you are using 30/70 premixed insulin formulation, so in 100 units, there are actually 70 units of NPH. So this 70 unit is basically a basal insulin component. So therefore, when you are shifting to the basal insulin or basal bolus regime, these 70 units of basal insulin will be there. Sometimes we reduce it by 20%. So therefore, you use 70 units minus 20% will come around 66 units. So you have to give 66 unit basal insulin when you are shifting from premixed to the basal insulin formulation. And then you have to add the short-acting insulin before breakfast, before lunch, and before dinner. Mind you that if you shift from the premixed insulin to basal insulin only, you will not be able to maintain the glycemic control. You can from class 5, you should go to class 6 and not class 4. So we start with basal insulin, then we go into premixed insulin, then we go to the basal bolus regime. So from premixed insulin, if you are writing basal insulin, you have to add the bolus insulin as well, with breakfast, with lunch, with dinner.
Okay, sir. So there's no more questions. So I'd request all the participants to kindly unmute themselves and ask if you have any question. No questions, sir, so far.
Okay, so let me go to the last part.
Last part, correct.
The last part is basically the case discussion that is Visible, Dipankar, slide?
Yes,
Yes,
sir.
sir.
Visible.
Yes, sir, visible.
Okay, can you mute the other people?
Yeah. Dr. Ashima Vishwas and Dr. Bishwarup Sen, can you please mute yourself?
Mute করেননি
Dr. Ashima Vishwas and Dr. Bishwarup Sen, kindly mute yourself. Yeah. Dr. Vishwas, can you please mute yourself? Dr. Ashima Vishwas. So you can start, sir.
Okay, so in this, I'll just give you some case studies which will give you a brief understanding that where the situations where actually we start insulin and where it is a very, very important to start insulin therapy. Now, first, I will discuss about weight loss in diabetes. Let us have a look into this particular patient. This is a 52-year-old male, not a known diabetic. He came in June 2009 with poor appetite, constipation, lethargy, weight loss, and all symptoms for the last 3 months and increasing gradually. He was appeared very weak and he was taking support to walk and stand. A 52-year-old man should not take support to walk and stand. Blood pressure was 120 by 80. There were a few crepitations in the chest. He was seen by a local physician who advised a lab test, and fasting was 209 and PP was 345, and the local physician started one oral anti-diabetic drug. I was very, very astonished to see that only with a fasting plasma glucose of 209 and PP 345, the patient became so weak. It is not acceptable. It was I could not relate the amount of symptom and the amount of hyperglycemia the patient had. So you can see that this is there is a I thought that this is something we have missed, because this amount of blood glucose level cannot cause this amount of weakness, so that a 52-year-old man, quite young, and taking support to walk and stand. So I looked into the other lab parameters the patient had, and you can see that after giving oral anti-diabetic drug, the blood sugar came down with A1c 7.4, and you can see everything more or less okay, except the hemoglobin level was 8.5. That also is not the explanation for this amount of weakness the patient had. So we have done an X-ray and we found that the patient actually had tuberculosis. So we started the insulin therapy and antibiotic, and over the period of time, he was evaluated, found to be just sputum positive, and there we have shifted the patient to Clargine at bedtime, regular insulin 3 times, and the anti-tubercular drug. So this is basically a Bezel bolus regime with which we should treat. So all patients who have infection, you should treat with Bezel bolus regime. So that is an important take-home message. And I think that all patients with tuberculosis, at least during the intensive stage, intensive therapy, we should treat the patient with insulin only. So how we can give insulin, as I have already discussed with you, that it is a 0.5 units per kg per kg that we usually give. So this patient has got a body weight of 52 kg, so he will require roughly around 26 units. And usually we give the 40% or 50% of the total dose of insulin as basal. So in 26 unit, 40% will be roughly around, say, 10 units. So we started with 10 units Clargine at bedtime, and rest all insulin with 3 divided dose. So 5 units regular insulin before breakfast, before lunch, before dinner. So this is the way we should calculate. So you must understand the calculation when we are starting the basal bolus regime. Also, you have to understand how to shift from premixed insulin to basal bolus regime. So this is the way we have calculated, and we started the anti-diabetic drug. The anti-tubercular drug continued. Patient progressively required the higher dose. The total dose of 46 units were required. Gained body weight, and over a period of time, there is a significant improvement in the X-ray finding, and patient recovered completely. If you look into the guideline as far as the World Health Organization is concerned, Diabetes is associated with increased risk of active tuberculosis. TB prevalence is higher in diabetics. Diabetes increases the time to sputum culture conversion. Diabetes increases the risk of death and risk of relapse. And management of diabetes and TB should be provided in the line with the existing guideline. And management of TB in diabetes should be provided in line with the recommended standard TB regimen. Means TB should be treated the way TB should be treated in non-diabetic subjects, and the diabetic should be treated the way you treat all diabetic subjects. Means in infection, you should start with the insulin therapy. Now, insulin in patient with inadequately controlled on weight. Now, this is a patient, 63-year-old male diabetic patient presented to the hospital with complaint of severe fatigue for the last 3 days. He had no complaint of frequent urination, bloody vision, wet loss, tingling, or numbness in the hand or feet, unable to perform his routine work. He was receiving metformin twice daily, glimepiride 2 mg, no history of hypertension or cardiovascular disease, did not exercise regularly, had a sedentary lifestyle, and he was a non-smoker. BMI 25, blood pressure 120/70, pulse 74. Respiratory system showed normal breath sound. Heart systems are normal, but with a bilateral sensory loss in the lower extremity, the patient has got a peripheral neuropathy. Now, fasting was 220, PP 310, A1c 9.4, ejection fraction 67, no microalbuminuria fundus normal. So this patient has got a very high glucose with A1c more than 9%, and therefore the patient should be on insulin. So as we know that our target to keep the H1s around 7 with preprandial target roughly around 80 to 130, and postprandial target is between say 130 to 180. According to ADA 2019 guideline, the recommended A1c level in current patients should be around 7%. So we have already discussed about the how to look into the issue. As I have told you, the entry age must be more than 9% with symptom. We should start the insulin therapy. But the patient has expressed a lot of concern about the insulin immunization. This is a very, very important challenge in front of us because many patients do not want to start the insulin therapy. That is why I have some strategies. Now, those patients who are under my care, I usually keep on talking about the insulin from the very first day. So just one sentence, many requires insulin. In the second visit, you should say that that when the diabetes becomes of long duration, patient should take insulin. Third visit, you can say the insulin is a very good form of therapy, but the patient is on oral anti-diabetic drug, well controlled, but still you talk a little bit of insulin every time patient comes to you. So in the mind of the patient, actually you cannot just one certain day you can say that you have to start insulin therapy right now. But if you keep on talking on insulin therapy, every time patient visits you, at least one sentence, that's it. So it gradually make the patient aware about the insulin. The fear of insulin therapy will disappear, and it will be easier for you to start the insulin when fear of lifetime.
Dr. Ashima Vishwas, can you please mute yourself? Dr. Ashima? Dr. Ashima Vishwas, can you please mute yourself?
Can you mute her from your side?
Sir, I can't do because you are the host. If you can make me co-host, then I can do, sir.
Oh, okay.
Sir, you can go to the participants below. There in my name, there is an option. Make co-host.
Make host. Okay.
Hello.
Sir, done that, sir. Done. Please go ahead.
So, so the complexity of the treatment regime is also an important issue in front of the mind of the patient. But as I've told you that the insulin therapy is not much complex. You just start with basal insulin. Do not make it very complex. Start basal insulin. gradually up titrate, and the possibility of hypoglycemia is very, very low. The cost of therapy is also not very high because the fact nowadays people use a lot of costly drugs. With compared to that, insulin therapy is not at all costly, provided you are using the cheaper options. And as far as the glargine is concerned, it is not very costly. But if you are using the degludec, then it will become very costly. Otherwise, glargine, and if you want to give very cheap insulin, then the NPH is an option in front of you. So coming to the barrier, which one of the important barrier is the pain as far as the injection is concerned. But nowadays we have very fine needle, 31 gauge, 32 gauge. Now people thought that it is difficult to give the insulin injection because we have pen, and pen is there with almost all companies, and pen is very useful, pen is very convenient, pen will give you pen ensures that the patient is receiving the exact dose. As because the patients are using pen, so the needle is very fine, so therefore it is almost painless. So pen, actually insulin pen, actually I feel has revolutionized the insulin management, and it had made it very simple on part of the patient and also on part of the physician who are treating the patient with insulin therapy. Many people believes that the insulin is associated with poor prognosis, but the education, I've told you, unless and until you educate, it is not the insulin that leads to poor prognosis, but it is the delay in initiation of insulin that leads to poor prognosis. People told me that once the insulin has been started, my father died because of renal failure. Because the fact that the patient has died because of the renal failure, and why the renal failure has occurred, it is because of the poor glycemic control. So we should start the insulin therapy at the right time, so that we can achieve a very good target, and so that the patient don't land up to the end-stage renal disease. Now, efficacy of early initiation of insulin glargine will give a better outcome compared to the oral agent, as this important study showed. If you give glargine, it produces the better outcome compared to the oral agents. Now, if we look into our case, the initial dose of insulin glargine was calculated based on patient A1c and H1 BMI using this formula. I don't use the formula. I start insulin 10 minutes, then progressively increase the dose. That is a very, very important option in front of you. Or otherwise, you can actually calculate on the basis of A1c and BMI formula. 18 units of bedtime insulin glargine was initiated. Oral metformin was continued, and patient was actually educated about the insulin injection techniques and the self-monitoring of the blood glucose. After 3 months, you can see that there is a significant improvement in the blood sugar level as well as the HbA1c. A greater improvement in glycemic level was noted at 3-month follow-up visit. The patient was reassured that with continuation of insulin glargine, the target glycemic goal would be achieved. Lifestyle changes were also emphasized. A follow-up visit after 3 months was advised. At follow-up visit 3 months later, general condition of the patient had improved and were able to perform his routine work. Coming to one case of diabetes in young, there's a 13-year-old girl presented with 2-week history of polyuria and polydipsia accompanied by 5 kg weight loss and blurred vision. Her medical history was unremarkable, no family history of diabetes, and you can see at the time of presentation blood glucose was very high, 263, 357, H1 at 10.9. So quite naturally, she was started with oral insulin therapy, multiple dose insulin therapy before breakfast, before lunch, before dinner, with 20 units glargine insulin at bedtime. Her symptoms and glycemic status improved in 6 weeks time, and you can see blood glucose level is quite improved with fasting 115 and before lunch, before dinner 121.65, indicating significant improvement in the glycemic status with the multiple daily insulin injection. So the A1c now 9.4 with the sugar level has improved a lot, and we have asked the patient to undergo the C-peptide, an anti-CAT and anti-IU2 antibody. C-peptide was very low with anti-CAT, anti-IU2 antibody positive, indicating we are dealing with type 1 diabetes. So in type 1 diabetes, we should always treat the patient with Bezel bolus regime. As you know that with Bezel bolus regime, the type 1 diabetes remains in a better control compared to any other regime. So therefore, type 1 diabetic subject should be treated with Bezel bolus regime. We don't start just with basal insulin, then we optimize, then we intensify. No, for type 1 diabetes, start with basal insulin, continue with basal insulin for the rest of the life. Now, as if we look into the International Diabetes Federation Atlas of 2019, India has got the highest number of adolescent type 1 diabetes, and we are in the world, and it is highest is India, second is USA, third is Brazil, fourth is China. So these are the top 4 countries having the highest number of type 1 diabetes in the world. Now, coming to the diagnosis of type 1 diabetes, how you can diagnose. Diagnosis of type 1 diabetes is purely clinical. You don't have to do C-peptide. You don't have to do autoantibodies. So young patient and not responding to oral anti-diabetic drug, and a patient who come with the classic manifestation, polyuria, polydipsia, polyphagia, marked hyperglycemia, non-responsive to oral agent, and the patient is young and they have a dependence on the exogenous insulin, indicates that we are dealing with type 1 diabetes. Only in rare cases we do test the C-peptide and the autoantibodies to get the confirmation. Now this is another young boy or young man of 27 who had beta thalassemia major since 2.5 years of age, and he was on regular blood transfusion. Splenectomy and cholecystectomy done in 2006, and came with in May 2006 with 10 kg weight loss in 8 months, and we found that the blood glucose level was very high, 362, 447, A1c 13.1, and this patient was basically at his secondary diabetes. So when you have the thalassemia, so these patients are at risk of development of the iron overload disease. So once there is an iron overload, it may affect many endocrine organs, including the pancreas. So when it involves the pancreas, there is a possibility of both endocrine and exocrine pancreatic problem. Now, if it involves the endocrine aspects of the pancreas, it may give rise to diabetes mellitus, and that is secondary diabetes. So we treated the patient with basal bolus regime, because secondary diabetes again to be treated with basal bolus regime, not with metformin or other oral anti-diabetic drugs. So in patient with thalassemia major, iron overload is a very, very important issue, and that leads to many iron overload diseases. In pancreatic volume is low among patients with this iron overload disease, or patients with beta thalassemia major. There is a higher possibility of hepatitis C and hypogonadism, and the patient usually have insulin deficient diabetes, but they can also have type 2 diabetes mellitus as well. The good chelation therapy is the most important approach in preventing the pancreatic damage, and if we can achieve a good iron chelation, that actually can prevent the development of endocrine organ damage, including the development of type 2 diabetes mellitus. A 28-year-old male admitted in our hospital with weakness and uncontrolled hyperglycemia. He actually had recurrent pain abdomen since childhood, large volume stool, and very high fasting and PP glucose 321, 386. And you can see this is the patient quite malnourished, and you can see very high blood glucose level. And we have done a radiological evaluation on a strong suspicion, and we found that there is a pancreatic calcification from this side to that side. And a poor nutrition, diffuse mild abdominal tenderness, and a mild absent subcutaneous fat, absence of buccal fat, parotid glands appears relatively large, and the patient had pancreatic calcification, so we were diagnosed of hypocalculous pancreatic diabetes. Now, fibrocartilous pancreatic diabetes is basically an unique form of diabetes found in some parts of the world, including India. Their BMI is usually low, less than 18. They're severe insulin requiring diabetic. Their requirement of insulin is higher than the type 1 diabetic subjects. A1c on presentation is very high, 9.7. C-peptide level may be normal, maybe subnormal. Uh, the pancreatic pain and steatorrhea are not always present, but many times we find pancreatic calcification. They usually don't develop diabetic ketoacidosis, even if the patient remains uncontrolled or without insulin for a long period of time. So this basically occurs in the tropical country. The presence of diabetes and evidence of chronic pancreatitis are three important points that goes in favor of the FCPT diagnosis. Again, in the management, because this patient pancreas is not working, we actually treat this patient with glargine and regular insulin 3 times. So we treat the patient with Bezel bolus regime. Now, this is another case, Miss Monju Das, 59 years, female, diabetic for the last 3 years, resides in a village near Bidnipur on irregular oral anti-diabetic drug. Her glycemic status was unknown to us, but he developed a painful swelling in the right eye 15 days back, contacted local eye specialist, antibiotic drops was given, but no improvement. And the glucose, when the glucose was evaluated, it was 332 and PP was 412. And was admitted in our hospital. You can see that the day 2, when I first seen this patient in the hospital, she was appeared very toxic, extremely weak, and speak very feebly. And you can see that there's significant involvement in the right eye with complete abscess and external ophthalmoplegia and dilated not reacting pupil on the right side. So what is your diagnosis? In a patient, those who have diabetes and this kind of eye involvement, orbital cellulitis is the one of the very, very important differential diagnosis in front of our mind. So let us have a look into the lab parameters. You can see that the blood count was not very high, blood sugar was very high, creatinine is normal, H1 is 7.4. It indicates that very recently the blood sugar level has gone up. And in CT orbit, congested retroorbital space with mass and needle aspiration with the retroorbital tissue was found mucormycosis. So this patient has got a mucormycosis. She received antibiotic, IV insulin, then shifted to the subcutaneous insulin and thrice daily, and then to regular insulin and glargine at bedtime. Now the patient received amphotericin B 1 milligram per kg body weight per day infusion over 8 hours for 4 weeks with local irrigation antibiotic therapy, and gradually the patient recovered from the problem. Now, secondary diabetes. This is a 62-year-old man who is diabetic for 6 years and hypertensive for 5 years. He came in our clinic for the evaluation of diabetes and hypertension, and now admitted in the hospital with uncontrolled hyperglycemia. Last visited the doctor about 7 months back, fasting 365 pp, 380 for H1c, A1.4. We have evaluated this patient physically, looking into his face, looking into his hand. We found that this patient hand is quite bigger compared to his brother. Body weight was 82. He had a deep voice, large hand, abnormal face, prominent acanthosis nigricans, and therefore it it appeared to us that this patient is suffering from acromegaly. So basal growth hormone was 20, 75 gram glucose suppression is absent. Pituitary macroadenoma was found without any cellular extension. So we had a diagnosis of acromegaly and treated the patient with subcutaneous insulin, regular insulin thrice daily, and glargine at bedtime, because all patients with secondary diabetes should be treated with a basal bolus regimen. Especially this patient will have to go for the surgery, pituitary surgery, and therefore you have to control the blood glucose very tightly with basal bolus regimen. So this is a 56-year-old female who is known diabetic for 11 years, presented to the diabetic clinic with complaint of increased fatigue and polyuria. She was on insulin glargine 10 units at bedtime and on weight glimepiride and metformin. She was not attending follow-up visits regularly and did not adhere to the instruction provided by the physio with regard to self-monitoring of her glucose level. Now, unless and until you titrate the insulin dose, you will never be able to achieve the target. So insulin dose titration is very important. If you have not titrated, you will remain here. You will never achieve the target. And the dose titration is patient specific and should be done in order to achieve target fasting plasma glucose level. And adequate titration of insulin dose either by physician or by patient. As I've told you, I always prefer to get the titration done by the patient himself, actually leads to a better outcome. The choice of algorithm may depend on clinical circumstance and the patient willingness and ability to become more involved in the therapy. In basal titration, as I've discussed with you, you can titrate with the 2 units every 3 days to the fasting plasma glucose value.
আমি পরে কথা বলছি।
So lower starting dose, slower titration, higher target may be recommended for those patients at higher risk of hypoglycemia. So we have to modify the insulin dose on the basis of the 3 values of fasting plasma glucose. And as I've told you, there are a lot of titration algorithm, but this is the algorithm which I personally follow. So I have shared it with you that you can also follow the titration algorithm. You have to increase or decrease the dose of the basal insulin depending on the fasting plasma glucose value. So you can empower the patient to self-titrate. That is very, very important, but the patient should be intelligent, patient should be educated, patient should understand, and patient should do it with responsibility and reasonably. So that is an important issue. If you find that the patient is quite educated and intelligent, you can entrust the patient to take control of his or her diabetes. And as I've told you, if you do titration by the patient versus by the physician, patient-led titration give better result. We have many digital apps for the titration. This is the app developed by Sanofi, and this was actually approved in March 2017. So you can actually ask the patient to download this digital app for the titration, and this app will guide the patient how much amount of insulin dose to be titrated, and that will give the patient more confidence as far as the insulin, its titration, and the glycemic management is concerned. Now, the other important method by which we can monitor the blood glucose is by looking into the continuous glucose monitoring system. This is also a method by which actually the patient can monitor his or her blood glucose level, and there are 2 continuous glucose monitoring system is there. One is Medtronic and Abbott, and these 2 systems actually slightly different with each other, but gives us an important feedback about the glycemic status. But they measure the glucose in the interstitial fluid, and the patient actually can look into his smartphone to get an idea what is the blood sugar level right now, because the electronically they can actually transmit the data into the mobile phone. This is basically a smart CGM nowadays we call that fits seamlessly into your life, that this Guardian Connect app. If it will connect with your mobile phone, the data will be generated and the data will be given to the mobile phone, so that in the mobile actually you can see the fluctuation of the blood glucose level after taking a meal or remaining in a fasting state. So every time you can check, every time you can see that what is the plasma glucose level right now. So these are the important advancement has occurred, and a patient, those who are quite knowledgeable, those quite tech savvy, for them these are the important option in front of us. They can use this option. They can actually do the continuous glucose monitoring time to time, say for example once in a year or twice in a year, to get an understanding about the glycemic control throughout the day. Of actually it is done for say 14 days, so you can get the data of 14 days how the patient behave in that 14 days time frame. And or for the titration, you can use many titration app. One is developed by Sanofi. There is a beautiful app with which the patient can be empowered to up titrate the insulin dose to get better control of blood glucose, especially the fasting plasma glucose with the basal insulin. So basal insulin allows optimal titration, less hypoglycemic risk, achieve and maintain glycemic goal in the safe and effective manner. So I informed to all of you, and I've told you repeatedly that the basal insulin is a very, very important method by which we can achieve fasting blood glucose, and this is associated with very less possibility of hypoglycemia. And if you can titrate the dose, you will be able to achieve glycemic target in 70 to 80% cases without making the regime complicated with other insulin or other anti-diabetic drug. So thank you very much for your patient listening, and if you have any question, then I can answer.
So we have one question. Twice daily Lantus